Thank you, Srinidhi. Good evening, everyone. Are you able to hear me and see the screen?
Yes,
Okay. Okay.
yes.
So, today's topic is peptic ulcer and gastritis. Before starting the topic, I would just brief all of us to some basics of GIT, acid secretion, and other uh, modalities about the cells, because each and every properties of cell of stomach and glands will be helping in both pathological and pharmacological modalities later on. तो हमें सबसे पहले ये आइडिया होना चाहिए कि हमारे स्टमक में हम उनको किन पार्ट्स में डिवाइड करते हैं. सो प्राइमरीली we divide our stomach into the cardiac zone as soon as we enter the esophagus. Then there is the fundus of the stomach, and then we have a large body. At the end, we have the pyloric zone, and just before pyloric zone, this is sorry, this part is called the antrum of the stomach. uh, in the glands of stomach, we have some very important cells. So, of course, surface epithelium lines the glands, which is cuboidal in nature. And then we have mucus cells for mucus secretion. And then ECL, enterochromaffin-like cells, which we'll be studying abhi just right now. Parietal cells, which are between mucal cells and chief cells. And chief cells secrete the protein pepsinogen and ghrelin cells. So, starting with how does acid HCl gets produced in the lumen of the stomach? We have enterochromaffin-like cells, जिसमें antral G cells गैस्ट्रिन रिलीज करते हैं एंड एंट्रोक्रोमैफिन सेल्स हैव CCK2R receptor for gastrin, जिससे the molecules get attached. Of course, there is anticipation and also the smell of food, the taste, or even the thought of food, which stimulates the vagal stimulation, which have their own roles. And then uh, the enterochromaffin cells releases histamine. Histamine binds to the H2 receptors of the parietal cells, and the parietal cells have a very important proton pump, H plus K plus ATPase, hydrogen potassium ATPase proton pump, which releases the hydrogen and chloride ions from cells into the lumen of the stomach. So, hydrogen and chloride ions are secreted from the apical membrane of gastric parietal cells. So, we saw the role of ECL cells, which releases histamine when antral G cells releases gastrin and binds to the CCK2R receptor, और histamine जब release होता है, it binds to the H2 receptor of parietal cell, and then hydrogen and chloride ions are secreted from gastric parietal cells with the help of proton pump. Now, HCl releases, but what does HCl actually do? So, of course, it has two very important roles. It sterilizes the upper GI tract, the esophageal part and the stomach part. So जो भी हमारे फूड में बैक्टीरिया या फिर जितने भी germs or unwanted particles होंगे, HCl has a role to destroy them. And the second most important role is HCl acts as a catalyst for pepsinogen conversion to pepsin, which helps in the protein digestion. Now, we also saw there are D cells. What does D cells do? Now we know antral G cells releases gastrin, जो acid secretion और mucosal growth में help करेगा. But what D cells does, it releases somatostatins, which inhibits the production of gastrin. मतलब G cells and D cells have very analogous different functions, and so D cell has, you can say, a regulatory function of in the stomach कि gastrin का regulation D cells से regulate होता है. The ghrelin cells are oxygenatic cells which regulate the gastric acid secretion, our appetite, the satiety and everything, and also gastric emptying. Now, there are also protective factors in the layers of the stomach. So, bicarbonate ions, which are stimulated by the prostaglandins, which will be seen just few minutes later, protect the mucosa from the ulcerative properties of HCl, and the mucins of trefoil factor family peptides also protect the mucosa of the stomach from the ulcerative properties of HCl, so that HCl does not corrode the mucosa. One important physiological mechanism of control of gastric secretion has to be understood by three phases. So there is cephalic phase, which is a neural phase, and it starts even before we get the food inside from our mouth. So even the sight, smell, or taste, or even thought of food has a role, and the acid starts getting secreted. Then there is, of course, the gastric phase, which is mechanical and is characterized by stretching of the wall. So neural messages के through mechanical stretching of wall होता है, and then chemical stimulation से gastrin gets produced. And then there is the intestinal phase, when there is entry of protein-rich food in the small intestine, so that now the G cells know that the food has traveled from stomach down to the intestine, and then it is self-regulated. One of the most important parts before we start talking about gastritis or peptic ulcer is how do we understand कि stomach अपना defense mechanism कैसे खुद बनाता है, कैसे उसके पास कुछ ऐसी चीजें हैं which regulates कि acid का balance बना रहे. So, of course, the upper part has acid, and then there is mucus. But there are also different things such as physical barriers कि हमारे cells, gastric epithelial cells जो हमने ऊपर देखे in the glands, they limit the back diffusion of acids. So acid का diffusion अगर cells में हो भी जाता है, तो this is also prevented by rich mucosal vasculature. So mucosal vasculature, apart from delivering O2 to all the cells, also removes acid which may have diffused. So physical barriers and rich mucosal vasculature can work together. Of course, then there is epithelial regeneration in every 3 to 7 days. So जो भी epithelial cells हमारे gastric glands के erode होते हैं, they already get regenerated in every 3 to 7 days. So we always have new cells coming up. And of course, prostaglandins, there is a very big role of prostaglandins because they release bicarbonate ion, and then they maintain the pH and the amount of HCl that is in the stomach. So we have to understand prostaglandins, PGE2 and I2 very carefully. So prostaglandins mainly help in more mucus secretion, in more mucosal blood flow. So वो कैसे होता है? Increasing the bicarbonate secretion and decreasing the gastric acid secretion, and epithelial repair में भी help करता है. So we know now कि prostaglandins have a very important role in maintaining the acid balance in our stomach. So the thing that we have studied in our second year, I would like to go into a little bit detail जो हमने सेकेंड ईयर में किया था, इन अंडरस्टैंडिंग द पॉक्स 1 एंड पॉक्स 2 पाथवे, द प्रोस्टाग्लैंडिन pathway in short, to understand the role of NSAIDs also, which will be dealing in detail in the later part of the presentation. But to understand it very मतलब easily, we have membrane phospholipids, जिसकी वजह से एराकिडोनिक एसिड बन रहा है, एंड देन वी नो दैट वी हैव टू pathways, COX1 pathway and COX2 pathway. So COX1 pathway is for housekeeping. It is secreted in stomach, kidney, platelets, and endothelium. And COX2 is related to inflammatory properties. So it's secreted in macrophages, leukocytes, fibroblasts, and endothelium. Now, where they work is also important. Kyuki COX1, as we said, is for housekeeping. So it secretes PGI2, PGE2, and thromboxane A2. So it is important for gastrointestinal mucosal integrity, platelet aggregation, and renal function. All three functions are very important in understanding of the concept of NSAIDs too. And COX2 pathway uh, releases PGI2 and PGE2, which is then causing the inflammation. Inflammation is causing all the five Ruber, Dollar, Calor, and mitogenesis, bone formations, and also COX2 in vascular endothelium produces PGI2, which inhibits platelet aggregation and causes vasodilation. So, uh, understanding this कि COX1 और COX2 pathways अलग अलग है, when we give non-selective NSAIDs like ibuprofen, diclofenac, they inhibit both the COX1 and COX2 pathways, reducing the prostaglandins and weakening the protective mechanisms in the stomach. Prostaglandins का already इतना बड़ा role है कि they are increasing the mucosal blood flow, they are increasing the mucus, and then also the bicarbonate ions. तो जब हम दोनों pathways बंद कर दे रहे हैं, and the chronic use of NSAIDs एक patient ले रहा है for some disease, or sometimes also irrational use of NSAIDs, then the person is bound to have very low, very weakened protective mechanism. And then we also have selective COX2 inhibitors, which spare the COX1 pathway. तो ऐसे वी कैन सी कि हाँ ठीक है, COX2 हम COX2 इनहिबिटर्स दे देते हैं तो COX1 काम करता रहेगा एंड द गैस्ट्रोइंटेस्टाइनल म्यूकोजल इंटीग्रिटी विल स्टे ऑन. बट we also got to know कि COX2 has a very big role in vascular endothelium. So when it is selectively blocked, PGI2 is decreased, and then thromboxane A2 is still produced, क्योंकि thromboxane A2 तो COX1 से increase हो ही रहा है, which is causing platelet aggregation. COX2 inhibits the platelet aggregation, और COX1 causes the platelet aggregation. तो अब thromboxane A2 भी produce हो रहा है and PGI2 भी decrease हो गया है, which is causing prothrombotic state in the body, and it increases the risk of myocardial infarction, stroke, and other serious disorders. So for this cause, when we prescribe the drugs, especially related to the NSAIDs, हम लोग को बहुत रिस्क बेनिफिट रेशियो के साथ we have to move on, and therefore FDA has removed valdecoxib and robecoxib from the prescription because they are very efficient painkillers, but they increased the risk of cardiovascular diseases. I hope I was not too fast and was able to clear the very initial part of the session. Sir, do you want me to continue, or do you have anything to add on?
I think actually you have covered the basic of physiology quite well. I'll just like summarize whatever you have told into some important terminologies that you need to remember while you are writing your answers. So, like whenever we are talking about gastric secretion, we have to think about three different pathways. One is a neural pathway, other is a hormonal pathway, and then there is a paracrine pathway. So the neural pathway is the one which is mediated by the vagus is and it has got acetylcholine as its intermediate, and it is directly acting on the parietal cells for gastric acid production. Now the hormonal pathways are all determined by the uh, the cells in the stomach. So the gastrin cell, they produce gastrin, and that also is involved in the acid secretion. And the paracrine pathways are also again determined by the cells in the environment. So depending upon the site of the stomach, the cell and the nature of the hormone produced is also different. The substance produced is also different. So the enterochromaffin like cells will produce histamine, while the enterochromaffin cells they will produce substances like atrial natriuretic peptide, serotonin, and adrenomedulin, which are all paracrine substances. They are also influencing the gastric secretion in the by acting on the nearby parietal cells. So that is how the three different pathways that are involved in the neural pathway, hormonal, and the paracrine pathway. Now, all this, the whole thing. So, to summarize the whole thing, you know that there is a vagus nerve which is connecting your brain to the gut, and the mediator is acetylcholine. And in the gut, you have your enteric nervous system, which has got neurotransmitters like acetylcholine, GRP, nitric oxide, VIP, and all that. And they will act on the target cells like your G cells, B cells, parietal cells, enterochromaffin cells, and they will produce certain neurosubstances, and that each of them have got some inhibitory as well as stimulatory functions on the surrounding cells. So to summarize, that is how the physiology of gut secretion is like, GI secretion is like. Okay, I think you can go ahead with the physiology.
Okay.
I hope I was clear with that. Like, I just summarize the whole thing that you mentioned
Yes, sir.
just to uh, focus on those terminologies.
Yes, sir. Yes, sir. Thank you.
Okay, okay, we'll go ahead.
So now coming to gastritis, as far as we know, gastritis, as Davidson describes, is majorly a histological diagnosis, but also it is also recognized at endoscopy. But by definition, gastritis is a mucosal inflammatory process. So there is also one term which is gastropathy. So when inflammatory cells are less in that process, we call it gastropathy. So gastritis can be acute or chronic. Acute onset में the gastritis is often erosive and hemorrhagic, and neutrophils are the predominant cells. Chronic में the predominant inflammatory cells are the lymphocytes, and the chronic gastritis का one of the main important causes which we are going to study today is H. pylori induced gastritis. Before we go to H. pylori, we have to understand some common causes of gastritis. So acute gastritis may and aspirin, NSAIDs are a very important cause. Helicobacter pylori, though I mentioned in the chronic, the initial infection, the patient can present with different symptomatology. We will be seeing ahead is quite matlab, different from all GI symptoms, and alcohol, drugs like iron preparations, in severe physiological stress such as burns, multi-organ failure, central nervous system trauma, these all things can cause acute gastritis, and they are erosive and hemorrhagic. Now erosions हर समय mucosa of the stomach को affect नहीं करता है, but they can be the patient presents with very critical symptoms and needs to be treated promptly. Chronic non-specific gastritis is majorly caused by H. pylori infection, autoimmune or autoimmune gastritis causing pernicious anemia, or post-gastrectomy gastritis. Some specific forms are, which we know is caused by CMV, cytomegalovirus, and tuberculosis. Crohn's disease, which is also a part of which is part of inflammatory bowel disease, and systemic diseases like sarcoidosis or graft versus host disease. Now coming to the important part of our today's discussion, Helicobacter pylori. Now this bacteria is quite amusing. It has इनिशियली इसके शेप में अगर हम जाए तो इट इज इनिशियल डिस्क्रिप्शन में इट इज अ ग्राम नेगेटिव बैक्टीरिया स्पाइरल इन शेप एंड इट हैज मल्टीपल फ्लैजिला एट वन एंड of its body. So multiple flagella at one end makes it very good motile, makes it as a very good motile organism, and it also has very important other factors such as VAC-A, CAG-A adhesins, which I will be describing now. So in here, let us imagine that uh, this is the H. pylori present in the acid layer. We have the mucosal layer here. लुइस बी एंटीजन हमारे बॉडी का एंटीजन है प्रेजेंट इन दी epithelial cells. So the flagella uses adhesin molecule to bind to Lewis B antigen, which is present in human body. So flagella of the bacteria tends to move to areas in pH close to neutral. So बहुत acidic environment में the bacteria is able to survive. ये उसकी एक अलग property है. But still, the flagella helps the bacteria in moving to areas where pH is little less and the acidic environment is less. The urease present in H. pylori generates ammonia, which increases the pH and increases its survival. So this bacteria is quite a very dangerous villain, I would say, because it has so many different factors. Now, CAG-A and VAC-A gene often confused with each other. We have to understand it clearly. The CAG-A is a pro-inflammatory and pro-proliferative gene, which is present in H. pylori, which increases the cell replication and apoptosis. And VAC-A gene is actually a large pore-forming protein, which increases the cell permeability and efflux of micronutrients from the gastric epithelium and induction of apoptosis and suppression of immunity. So, flagella, urease, CAG-A, and VAC-A, these all adhesins and other proteins, along with host के factors like interleukin 1 beta and TNF alpha, इनके polymorphisms की वजह से the immunity of gastric mucosa is decreased and H. pylori gets the opportunity to enter the inside the mucosa, inside the मतलब facing all the barriers that we studied during the defense mechanisms and move inside the gastric glands and ultimately to mucosal layers. Now, H. pylori का distribution and severity determines our clinical outcomes with the patients that present to us. So we have to understand the natural history of H. pylori infection. अभी the factors which I said, इन factors ने अच्छे से काम किया and the H. pylori has entered into gastric mucosa. We can have an acute H. pylori infection too, which we saw above. If unresolved, it slowly develops into chronic H. pylori infection. And then we have 3 types of gastritis, which causes different things according to severity and the distribution in the stomach wall. Now, अगर antral predominant gastritis है, now also understanding कि antral predominant gastritis, non-atrophic pangastritis, and corpus predominant atrophic gastritis All three of them can cause asymptomatic H. pylori infection. So, a patient as old as 65, 70 years of age might have a very high inflamed H. pylori infection but remain asymptomatic. And कभी भी अचानक से the patient might come with hematemesis or hemorrhagic causes and in a very critical state. So, all three of them can cause asymptomatic H. pylori infection. Coming to antral predominant gastritis, this pattern causes hypergastrinemia. So, there is very exaggerated high production of the acid. This is seen in a smaller proportion. Major patients have non-atrophic pangastritis, which causes asymptomatic H. pylori infection, and mild lymphoma will be seen in just a minute. In very much smaller proportion, patients have corpus predominant causes, which causes gastric atrophy and hypochloridia. अब इसकी वजह से क्या होता है? Gastric atrophy is gastric atrophy causes increase in reactive oxygen species (ROS), overgrowth of other coliform bacteria, which were dormant and even not which did not have uh, the suitable environment due to HCl, and loss of sonic hedgehog expression. मतलब mainly not also necessary to remember the all terminologies, but understanding that it is a main cause of cell polarity and it exposes the cell to mutagenic agents. Malt lymphoma, which is caused by non-atrophic pangastritis, is caused due to intense inflammation of lymphoid follicles and prominent germinal centers. So, H. pylori, again, हम सबके अंदर we have been we almost a very large proportion of our populations is infected with H. pylori. But we all don't have H. pylori, peptic ulcers, or infections. Why? Because we have to understand that there are many factors which play the role in causing gastric ulcers, duodenal ulcers, or even gastric cancer. So, of course, we एक इनिशियल तो होना चाहिए कि वी हैव एच पाइलोरी बैक्टीरियल इन्फेक्शन द होस्ट फैक्टर्स व्हिच आई टोल्ड कि इन्फ्लेमेट इंटरल्यूकिन 1 बीटा एंड टीएनएफ अल्फा के पॉलीमॉर्फिज्म्स की वजह से द गट इम्यूनिटी इज रिड्यूस्ड सो अगर इफ द होस्ट एक्सपीरियंसेस chronic episodes of stress, anxiety, and physiological stressors in body, and is a regular smoker, is a regular user of NSAIDs, ये सारे causes हो जाते हैं to cause antral or pangastritis. Antral gastritis leads to duodenal ulcers, and pangastritis leads to gastric ulcers or gastric cancer again. Gastric ulcer is less severe than duodenal ulcers. No, sorry, gastric ulcers are more severe than duodenal ulcers and may proceed in sequelae to cause even gastric cancers. Coming to what we studied above, a little about prostaglandins, COX-1, COX-2 pathway. I won't repeat the pathways again, but we have to understand the role of NSAIDs in gastritis because in future, as we also enter into internship, we will be having a great set of NSAIDs in our tables, and we have to decide कि painkillers और NSAIDs का role हमें कितना we have to move on with risk-benefit ratio. So, this table is important because it shows कि when we see selective COX-2 inhibitors, celecoxib and etoricoxib, they are very low risk in causing gastrointestinal bleeding and perforations. But again, we saw कि अगर हम सेलेक्टिव कॉक्स 2 इनहिबिटर्स देते हैं, we also increase the risk of cardiovascular diseases. The medium risk, the 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 most common medicines, ibuprofen, naproxen, and diclofenac, have medium risk in causing gastrointestinal bleeding, and uh, they are non-selective COX inhibitors. So gastrointestinal adverse effects are more likely even with PPI therapy. And high risk indomethacin, ketoprofen, and piroxicam have high incidence, high risk of causing dyspepsia and CNS side effects. So, when we have older patients, we have to see very surely if they need medicines which can cause high risk of gastrointestinal bleeding, because we also saw that NSAIDs are also one of the most important causes of acute gastritis. So patients can come in a very bad state and they might have a very poor prognosis too. Also understanding that dyspepsia, which we studied in our first section, is a poor guide to present in the presence of NSAID associated ulceration and bleeding. So dyspepsia शायद से complain हो भी ना patient का, and the patient presents with different complaints altogether. The NICE guidelines advises PPIs should be commonly co-prescribed with all NSAIDs. But also chronic PPI therapy is also associated with increase of hip fracture. So in older patients, we have to consider, again saying sorry for repeating, but risk benefit ratio needs to be reconsidered. Risk factors for NSAID induced ulcers is, of course, older age groups, more than 60 years. If there is a past history of peptic ulcer, if there is a past history of adverse effect with any NSAIDs, any allergic causes or drug allergies, concomitant glucocorticoid use, which already is decreasing the gut immunity, and high dose or multiple NSAIDs. The person has been on, if the person has been a patient of osteoarthritis, rheumatoid arthritis for a very long time and has been taking NSAIDs for a very long time. So, NSAIDs induced ulcers का एक बहुत बड़ा risk है. So there are few recommendations for use of NSAIDs. कि use the lowest dose for the shortest time possible to control symptoms. जिन patients में already warfarin चल रहा है, we have to avoid NSAIDs like aspirin and others. We have to allow 2-3 weeks to assess the efficacy. If response is inadequate, consider a trial of another NSAIDs. Do not continue with the same NSAIDs if the patient is unresponsive. And never prescribe more than one NSAID at a time. Co-prescribing a proton pump inhibitors for patient with risk factors for gastrointestinal adverse effects, and avoid in patients with any vascular diseases or even in the risk of vascular diseases. So in old age specifically, we have to remember in 3 headings कि NSAIDs की वजह से we can have gastrointestinal complications, which we saw, cardiovascular disease, use NSAIDs with caution because they can exacerbate hypertension and heart failure, and renal diseases too, because NSAIDs causes fluid retention and renal prostaglandin productions, which prostaglandin production is decreased. If you remember, we saw in the pathway that COX-1 also helps in renal function. So NSAIDs also impair the renal functions and therefore have to be used very judiciously. So NSAIDs I have described here because this can come as a short note. Already NSAIDs is a very important topic in understanding the clinics also. Now we start with peptic ulcer disease. So after a brief description of gastritis, peptic ulcer disease occurs most commonly in stomach and duodenum. It can also occur in lower esophagus, jejunum if there is a surgical anastomosis with the stomach, and even in ileum, but in very rare cases. If we see here, this is the image taken from Robbins. Uh, we saw the protective factors. I won't describe it again. I have mentioned it at the above. We have injury due to H. pylori, NSAIDs, tobacco, alcohol, gastric hyperacidity, duodenal gastric reflex. There is damage. If there is chronically damaged, there are impaired defenses in our gastric glands. It causes ischemia. Also, ischemia in the mucosal vasculature, shock, NSAIDs can cause acute uh, injuries, and then a ulcer is formed. The ulcer bed, from a pathological point of view, is important because it has, first of all, the necrotic debris, which is uh, uh, which is present at just the level of mucosa. Then there is non-specific acute inflammation, which might have neutrophilic infiltrations or even lymphomatic infiltrations in chronic cases. There is granulation tissue formed, and the muscularis mucosa gets fibrosis. Fibrosis is not seen in acute ulcers because fibrotic scars and fibrosis itself takes time. So it is always seen in chronic lesions. Peptic ulcer disease is actual a chronic condition. The patient presents with similar or dissimilar symptoms throughout his or her life, with spontaneous relapses and remissions lasting for decades, even if we say till the natural death of the patient. The most common presentation, but the patient presents is with recurrent abdominal pain, and we have to describe the abdominal pain with respect to three things. That is, it will be majorly localized to epigastrium region of the abdomen. It has some relationship to the food. So relationship to the food decides कि वो duodenal की तरफ जाएगा या gastric की तरफ जाएगा. And episodic occurrence की, is it very regular, is it weekly, monthly, uh, multiple times in a day, what is the episodic reoccurrence. The patient might also present with occasional vomiting. It is seen in 40% of the subjects, and persistent daily vomiting suggests that the patient might be having gastric outlet obstruction, which is also a complication of peptic ulcers, which we'll be seeing sometime later. Occasionally, the only symptoms which the patient presents with is anorexia and nausea and early satiety after meals. So very unusual, no? मतलब हमें ऐसा लगता है कि पेप्टिक अल्सर के पेशेंट्स विल ऑलवेज प्रेजेंट विद, हाँ डॉक्टर यहाँ पे पेन हो रहा है, मुझे यहाँ पे ऊपर ऊपर थोड़ा सा जल रहा है, ऐसा लग रहा है कि मतलब कुछ रिफ्लक्स आ रहा है, खाना ऊपर आ रहा है और बहुत अजीब सा लग रहा है. बट समटाइम्स द पेशेंट ओनली प्रेजेंट्स विद कि डॉक्टर भूख कम लग रहा है, आई एम नॉट एबल टू ईट वेल, आई फील वेरी नॉजिएटिक during my meals before or after, and there is early satiety after meals. So these complaints are often seen with gastric ulcer patients. In some, although very rare, ulcer is ultimately very silent. So, the patient might present with anemia from chronic blood loss, abrupt hematemesis, or acute perforation. So, understanding the our limit in the history here, key peptic ulcers can present, patients with peptic ulcers can present actually with everything or anything. So we have to actually move on with the history, the comprehensive history कि NSAIDs, alcohol ये सब का कितना use है, and then moving to investigations. Sir, do you want to add something before I move to gastric versus duodenal ulcers?
No, you can go ahead with that. Maybe at the end of it, I'll just summarize and tell you some important points regarding H. pylori and SAD, gastric and duodenal ulcers.
Yes. So now moving to what we have also studied in pathology in our second year, this forms a very important part of understanding gastric and duodenal ulcers. So gastric ulcers uh, are actually less common to what we believe in the common populations की हाँ stomach में ulcer हुआ होगा, but it is very less common, and duodenal ulcers are more frequent, actually 4 times more frequent, and it occurs in the age of 30 to 60 years, while gastric ulcers are usually seen above 60 years, above 50 years of patients. Location में we have to understand gastric ulcers most commonly occur on the lesser curvature of the stomach. तो टाइप 1 अल्सर जब लेसर कर्वेचर में आता है वी कॉल इट टाइप 1. टाइप 2 is the part where we share the duodenum and the gastric locations. Type 3 is the pre-pyloric region, and type 4 is the cardiac region. Duodenal ulcers are mostly seen in the first portion of duodenum, that is also called duodenal bulb. So, over 95% of patients present with duodenal ulcers in the upper part of the duodenum. Duodenal ulceration को समझने के लिए we also have to understand कि first there is depletion of antral D cell somatostatin. If you remember, we started with the शुरू of the lecture कि D cells or somatostatin acts as a negative stimulant for gastrin. Then there is, of course, other D cells decrease होगा तो there is increased gastrin from G cells, and then increased acid secretion. The increased acid load in duodenum leads to gastric metaplasia. Gastric metaplasia is important to know because H. pylori cannot invade into duodenal pura musculature and the gland and even the esophagus till there is metaplasia in the glands. So if the patient has duodenal ulcers, we we get to know he already gastric metaplasia has got started, and other the last further inflammation, chronic inflammation, eventually leads to ulceration. The shape of ulcers, again, pathological point of view, is uh, usually saddle shape with part of the ulcer on both anterior wall and part on the posterior wall of the stomach. And duodenal ulcers may they are usually round, where ulcers are more present on the posterior wall and are larger than those in the anterior wall. Both of them have common causes, which we have studied above. In duodenal ulcers, Zollinger-Ellison syndrome, malignancy, vascular insufficiency, and history of any chemotherapy are also few of the added causes. Now, the most important, pain. How does the patient describe pain in both ulcers? First, coming to gastric ulcers, patient says कि डॉक्टर पेन हमारा खाने के बाद इंक्रीज होता है. Whenever I eat meals, the pain increases. Why? क्योंकि जब खाना अंदर आता है, the gastric starts its action. There is constriction of pyloric sphincter. क्योंकि pyloric sphincter चाहता है कि स्टमक अपना काम अच्छे से with patience करे, so it doesn't allow the food or the exhale content to go out. The retaining of food is there for digestion, and food plus lots of acid, क्योंकि patient का already ulcer develop हो चुका है, there is gastrin. So while we have taken the meals, after 30 to 1 hour or even before, the patient starts having pain episodes. Though there is no radiation of the pain, but the patient says again and again, he uh, जब भी मैं खाना खाता हूँ उसके थोड़ी देर बाद ही मेरा पेन शुरू हो जाता है। Duodenal ulcers में it improves after meals. Why? It actually the pain starts after 3 hours after eating. तो हमारे मतलब any human being but also in Indian settings we casually eat after 4 to 5 hours normally. हम ब्रेकफास्ट खाएंगे फिर देन वी हैव लंच एंड देन स्नैक्स इन द इवनिंग एंड देन डिनर. सो पेन स्टार्ट्स एक्चुअली 3 hours आफ्टर ईटिंग क्योंकि द पाइलोरिक स्फिंक्टर रिलीजेस इटसेल्फ, मतलब डायलेट हो जाएगा. द एसिड अलोंग विद द फूड ट्रेवल्स डाउन द डिओडेनम एंड देन पेशेंट कैसे प्रेजेंट करता है. डॉक्टर, रात में मैंने खाना खाया, आई स्लेप्ट पीसफुली फॉर 3-4 hours, नथिंग हैपेंड एंड देन आई सडनली woke up with pain which was radiating, which was or not might, मतलब it's not compulsory radiation will be there but radiation is mostly seen. सो पेशेंट को ऐसा लगता है कि अभी मैं खाना खा लूंगा तो एसिड सिक्री पाइलोरिक स्पिंक्टर विल अगेन क्लोज इटसेल्फ. डिओडेनम पे एसिड और फूड नहीं जाएगा. द स्टमक में ही HCl का एक्शन होता रहेगा और मील्स के बाद उसे लगेगा कि हाँ अब तो ठीक लग रहा है. बट जैसे ही स्टमक गैस्ट्रिक एम्प्टिंग होगा द duodenal ulcer gets irritated and the patient starts feeling the pain. So it is very important in the history taking कि patient pain कैसे describe करता है. वेट लॉस, यस, क्योंकि रिड्यूस्ड इनटेक है इन गैस्ट्रिक अल्सर्स. क्योंकि जब वो खाना खाने जा रहे हैं, वो जब खाना खा रहे हैं दे हैव पेन, तो पेशेंट सोचता है खाना ही नहीं खाता हूँ, ऑलरेडी नॉजिया फील हो रहा है, बाद में पेन होगा, देर इज रिड्यूस्ड इनटेक. क्योंकि वी टेंड टू फील कि इफ वी ईट लेस देन वी वुड हैव लेस पेन एंड देन देर इज वेट गेन, very opposite to the gastric ulcers. क्योंकि there are improved symptoms तो पेशेंट को ऐसे लगता है कि अच्छा खाना खा लेता हूँ पेन ठीक हो जाएगा. क्योंकि द कॉन्स्टेंटली जब खाना स्टमक में जाता रहेगा तो डिओडेनम will not get irritated. Hemorrhage, if where whether there would be bleeding, yes, there would be more likely bleeding in gastric ulcers and the patient presents with hematemesis as a emergency condition. And bleeding is less likely in duodenal ulcers. If they bleed, they present with stools, which we know as melena. But duodenal ulcers are more prone to perforation. How do these ulcers look? So, in the endoscopy, we can see here that is the first image is the benign duodenal ulcer, and the second is the benign gastric ulcers. This is how often we see in the endoscopic images. When we see from pathological point of view, we describe the ulcer is sharp, punched out, rounded, and oval orifice hoga to the ulcer crater with overhanging margins. These are the overhanging margins. So this is this part of the discussion. Gastric versus duodenal ulcers can come as a separate short note and therefore it is very important. Now coming to management. Of course, endoscopy is the most preferred investigation. Uh, uh, though endoscopy will be discussed later. Therefore, I have not included indications for endoscopy and everything. But uh, we also have to know कि, for patients with GERD or acute symptoms, endoscopy is not normally preferred. It is generally preferred when patient presents with strong history of uh, symptomatology of peptic ulcers, of a very strong chronic use of NSAIDs or suggested history. Then, how do we move on with the endoscopic diagnosis? Normally, it is a standardized guideline. If the doctor, the surgeon who is performing the endoscopy, uh, has to also take the biopsy for uh, uh, serology for histology, and microbiology.
Akriti, you're not audible.
I think she has lost her connection.
Yes, sir. I will check once. She is rejoining, sir.
Based on the age and initial presentation. Then another is if there is any consistent history of melena, altered stool colors, or if there is any unexplained anemia, especially iron deficiency anemia, then also we have to consider that it is most likely an organic pathology rather than functional. Then association with the persistent vomiting, then progressive dysphagia, and cetophobia. Cetophobia means the patient feels like afraid to eat. So cetophobia is again most likely to be considered as a part of organic disorder rather than a functional disorder. And again, unintentional weight loss also, it will go along with this. If there is an unintentional weight loss, that also has to be considered as organic.
Thank you, sir.
Yeah, so while Akriti joins, I'll just go through some interesting aspects of like H. pylori infection, and I'll just add on some points which she has mentioned on. So, like usually, your H. pylori is an infection. So, why is an acute infection? Like, is an acute H. pylori infection possible, or is it only chronic? So that has been a question that has been there like since the discovery of H. pylori. So, acute infection is usually asymptomatic because what happens is during the acute infective phase, usually the bacteria will increase the somatostatin levels and reduce the gas and reduce the acid production. So usually in the early phases, the patient might be asymptomatic. Sometimes even the acidic symptoms or the gastric symptoms because of hyperacid like gastric secretion might subside in the early acute phase of infection. So usually we don't get a patient with an acute H. pylori infection. But when is H. pylori infection significant? When it becomes a chronic one. So once there is a chronicity of H. pylori, it can go into two ways. One is an antral predominant gastritis, another is a pan gastritis. So what is an antral predominant gastritis? Antral predominant gastritis usually around 15 to 20% of all patients with chronic H. pylori infection, they'll have an antral predominant gastritis, where the antrum is the one that is mostly involved in like H. pylori colonization. So what happens is when there is an antral predominance, it reduces the somatostatin levels, and thus the feedback inhibition is reduced. So it increases the gastrin levels. Because of increased gastrin, it increases the acidity. So what happens when there is an antral predominant gastritis and increased acid? This acid is mostly refluxed into the duodenum, D1. So in antral gastritis or antral predominant gastritis, these patients might usually present with duodenal ulcers. And this is mostly because of an increased acid. Now, what about gastric ulcers? So usually gastric ulcers are not because of increased acid. It is because it is commonly seen in patients with decreased acid. Now that's a corollary or a paradox because in pan-gastritis, what happens is the entire stomach is infiltrated by the H. pylori, and what happens is because of this the entire gastric acid production is reduced. Now there are multiple mechanisms that H. pylori uses to reduce the gastric acid production. An important one is that it produces autoantibodies. So the antibodies are against H plus K plus ATPase. So it is a form of autoimmune gastritis. It produces antibodies against H plus K plus ATPase. It is very similar to the mechanism of development of autoimmune gastritis. That's what it's called. I just mentioned it together. So then pan gastritis results in reduced acid production. And the gastric ulcer that is formed mainly it forms mainly because of the reduced or impaired barriers rather than increased acid. So that is one like interesting aspect regarding gastric ulcer and antral ulcer and duodenal ulcer. And again, whenever the patient is on aspirin or whenever the patient is on an NSAID, the usually there is a crosstalk between your H. pylori and your NSAID. So an NSAID induced ulcer in a patient with H. pylori will have usually lesser risks of rebleedings. So that is because of this chronic H. pylori infection, the net acid production as such is less. So the pure pathology is because of the NSAID itself is what is causing local ischemia and bleeds. And if the patient is eradicated of H. pylori, if the patient does not have an H. pylori infection, then the risk of rebleed from an NSAID is more. So that is like it's a very interesting thing. So there have been a school of thought which says that H. pylori is actually protective. Now, that is a very interesting idea that it was initially there when H. pylori eradication treatments started. There used to be an era where people used to protest for saving H. pylori. So that is one interesting aspect of H. pylori. And another thing is like regarding your like ulcer formation. So as I mentioned, your duodenal ulcers, these are all because of excess acid, and your gastric ulcers are usually because of low acid and impaired barriers. And usually your gastric ulcers, whenever you are finding a patient with gastric ulcer, you should know that it is in the background of a pan-gastritis, chronic infection, and atrophy. So always the risk of malignancy is much higher in a gastric ulcer rather than a duodenal ulcer. So whenever you find a patient with gastric ulcer or suspecting that the patient is having gastric ulcer, the risk of malignancy is also much more. So Akriti, can we continue?
Yes, sir. Sorry,
I hope.
my Wi-Fi got disconnected.
Oh, no problem, no problem. We'll just finish it up.
So, I hope I was audible till before management. So, can I start with methods for diagnosis of H. pylori infection? So, uh,
Yeah,
we
yeah,
have
we'll discuss regarding the management, and the endoscopic part we'll keep it till for the next session, I think, because we are
yes,
dealing with the endoscopic management as a separate part later on, I think. Yeah.
yes. So, in
Okay.
diagnosis,
Okay.
uh, uh, two important methods which are very highly sensitive, cheap, and specific to are C-urea breath test and fecal antigen test. So they they are very acceptable methods. The acceptability is a little disadvantage, but they are very cheap. The results come out very fast, and then of course, after the antral biopsy, we have the histology, which is very specific, and sometimes they can produce false negatives, but very rarely. And histology takes several days to process. So, especially in a primary care or a secondary care setting, if we don't have good histology labs, so this might be also be a limitation for endoscopy biopsy. Rapid urease test is a cheap, quick, specific test, and microbiological culture, of course, is the gold standard. It defines the antibiotic sensitivity, and since peptic ulcer incidence and the prevalence of peptic ulcer disease has increased in lower middle and lower middle and middle income countries so much. So currently we are also seeing antibiotic resistant strains, and therefore macrobiological culture also stands strong even after endoscopy. Though it is slow and laborious, but it is still the gold standard of the diagnosis. Coming to treatment, now we said the patient is actually, once the patient have a peptic ulcer disease, he or she has chronic remissions and relapses of the infection. So till they uh, try and uh, emit all the factors which were affecting the their ulcers and the infection, the aim of the management will always be to relieve the symptoms, induce healing, and prevent reoccurrence. H. pylori eradication is the cornerstone of therapy. And just now, Sir said there is also a school of thought which might think H. pylori are protective in nature. It is very interesting itself to understand. We also have to understand there are indications for H. pylori eradication. So, all the factors that the patient has peptic ulcers, extranodal marginal loans, lymphomas, mild lymphomas, there is family history of gastric cancer, there has already been diagnosed gastric cancer and resection of gastric mucosa, H. pylori positive dyspepsia, long-term NSAIDs use, chronic PPI users, or extra gastric disorders like unexplained vitamin B12 deficiency or iron deficiency anemia. So we all have to consider H. pylori eradication. It is not indicated in GERD and asymptomatic people without gastric cancer risk factors. Now, coming to little part of our pharmacology, I will try to limit to only important points here. We have to know the classification of peptic ulcer drugs. So there are drugs that neutralize the gastric acid, and therefore they are known as antacids. They neutralize the gastric acidity by increasing the pH. They are of two types, systemic and non-systemic. So non-systemic is not absorbed in circulation, while systemic is absorbed in circulation. Systemic is the example is sodium bicarbonate, and non-systemic, which we is a very household name of the medicine, Digene. Is the constituents of Digene is uh, magnesium hydroxide and aluminum hydroxide. So we have to know antacids provide rapid relief of symptoms in hyperacidity as they chemically neutralize the acid. But ऐसा नहीं है कि they are used for a very long मतलब ulcer healing and reducing the acid secretion. It only increases the pH, and there also could be rebound hyperacidity due to raised gastrin levels. So the duration of action of antacids is generally 30 to 16 minutes when taken on empty stomach. And we also have to, while we counsel the patients of iron deficiency anemia, we always say कि antacids, कोई भी अगर आप खाना ले रहे हैं या फिर antacids ले रहे हैं, तो you cannot take iron medicines. And the medicines mentioned here, such as many antibiotics, tetracyclines, fluoroquinolones, sulfonamides, digoxin in cardiovascular diseases, and even ranitidine, because it decreases the efficacy of bound drugs, and it is generally matlab avoid. So antacids should be taken 2 hours before or 2 hours after these drugs. H2 receptor blockers such as cimetidine, ranitidine, famotidine work as by blocking the H2 receptors on parietal cells, which we saw above. If you remember, the ECL cells histamine release pairing, and it binds to the H2 receptors. So there is decreased acid secretions, and both volume and acidity of basal, nocturnal, and food-induced secretion are reduced. The inhibition is dose dependent, and a single dose can cause 60 to 70% reduction in gastric secretion for 12 hours. Ranitidine is a preferred H2 blocker, then cimetidine because it is longer acting, first of all. Then we might know cimetidine has also uh, anti-androgenic effects. So ranitidine does not have anti-androgenic effects, uh, does not increase prolactin levels, and does not influence estrogen metabolism. There are no CNS effects seen in ranitidine because it does not cross blood-brain barrier and does not inhibit microsomal enzymes significantly. So there are no related drug interactions. Only adverse effects or side effects which we see in ranitidine might be headache and dizziness. Now coming to a very important class of drugs, the proton pump inhibitors. How does they work? So omeprazole is a prototype that majorly used for describing the proton pump inhibitors. How does it work? So omeprazole, these are prodrugs. So the proton pump inhibitors are usually present as enteric tablets and gastrin resistant proton pump inhibitors. You will see written gastrin resistant pantoprazole, gastrin resistant. So along with this, these are also prodrugs. So these are activated inside when they reach the GI tract, and then it converts into sulfonic acid, which again converts to sulfonamide. It forms covalent bond and binds and inhibits the HKK plus ATPase pump and decreases the gastric acid secretion. While ranitidine action is for 12 hours, proton pump inhibitors, when taken 1 or half an hour before food, stays active for next 24 hours. Just 1 minute. Yes. So, among PPIs also, pantoprazole is more acid stable, has higher oral bioavailability, and an intravenous formulation is also available. So, nowadays, uh, more than omeprazole, pantoprazole is majorly seen in the markets and in pharmacies. And when given as continuous IV infusion for 24 hours, inhibition of acid secretion is maximum. There are also other uses of PPIs other than the treatment of peptic ulcers, GERD, gastric esophageal reflux disease. It needs PPIs for 6 to 8 weeks. Ulcers heal fast and pain is relieved. But patients have to also comply with other uh, general lifestyle factors along with PPIs. Dyspepsia. H2 blockers are preferred for non-ulcer dyspepsia, but PPIs may also be used. Drug-induced ulcers, else. So we also discussed NSAIDs के साथ PPI तो लगेगा, and H pylori regimen में PPI would be there. Zollinger Ellison syndrome, though it is quite conflicting. PPIs are the doctor in Davidson. It was written we sometimes the doctors, one school of doctors uses large matlab amount of PPIs for a very long time because it helps in ulcer healing, multiple ulcers healing in ZN syndrome. Gastrinomas, which cannot be surgically removed, could cause peptic ulceration, and PPIs are useful. And pre-anesthetic medications to reduce gastric acid secretion, PPIs are used. We should also understand the adverse effects of these drugs. So prolonged acid separation may allow bacterial overgrowth in the stomach, resulting in increased risk of gastrointestinal infections. So, other there is irrational use of PPIs because also we know PPIs are available in over-the-counter medicines फार्मेसी में ऑफकोर्स जैसे ही हम पैंडी या पैंटॉप बोलते हैं वो तुरंत दे देते हैं, तो पेशेंट टेकिंग pantoprazoles and different medicines for a very longer time without any fine diagnosis can have increased risk of gastrointestinal infections. Dizziness, headache, diarrhea, abdominal pain, asphalgia, and rashes are very rare but can be there. Long term administration may result in विटामिन B12 deficiency क्योंकि reduced absorption हो जाता है. As we also know कि intrinsic factor के लिए HCl is also needed. Acid is also needed for absorption of magnesium, calcium and iron. So elderly patients जब PPIs लेते हैं, they need to check also the calcium levels in the body and bone density as they might have increased risk of osteoporosis and increased gastric levels due to reduced gastric acidity on discontinuing the PPI, sometimes abruptly. This may raise gastric and hyperacidity may remain for some days. Atropic changes in the stomach have been noticed after 3-4 years of use. So this table is taken from Harrison. So the things I said for the potential adverse effects of long-term proton pump inhibitors are majorly because magnesium, iron, and different absorptions are impaired. So hypermagnesemia, community-acquired pneumonia, because immunity is also reduced, bacterial overgrowth is there, Clostridium difficile infection, which is also caused by a very important famous drug, metronidazole also. Bone fractures due to reduced calcium levels and also impaired kidney diseases. Now we also have ulcer protective drugs such as sucralfate. It is a salt of sucrose and sulfated aluminum hydroxide. Now, these are not replacing PPIs or
Akriti,
any
sorry to
other.
interrupt you.
Yes.
Actually, we are
Short
we
of
have completed like 1 hour 20 minutes of this. So management of H. pylori, I think, is a large topic. Sir, could we take this for the next session along with the other topics, sir?
Yeah, I think we'll conclude and we'll take the treatment aspect of H. pylori and endoscopy and all the stuff in another session.
Okay, sir. Sir, meanwhile, just I wanted to clarify a couple of doubts.
Yeah, sure.
When we consider the H. pylori, sir, whether should we consider it as a normal colonizer of the GI mucosa, or whether it is a pathogen by itself? Because what I see in practice also, long-term PPI is given left and right in practice to patients who come with functional dyspepsia. So people, as Akriti has also mentioned, they are taking a lot of PPIs directly from the market as well. So, and many of the time, even endoscopy is also misused or overused, and people come with diagnosis of enteral gastritis or pan gastritis like that with minimal symptoms. So, in these cases, it becomes difficult whether we have to give them H. pylori eradication and PPIs or only give a trial of PPIs, and how what is the role of lifestyle and health and lifestyle and diet actually in all these dyspepsia cases.
Okay, so that was a very interesting question as well as a very interesting practical aspect also. So I'll deal it into two parts. So first thing is to know what H. pylori is. Second is as asymptomatic H. pylori significant? So one thing is like for all practical purposes, only if the patient is symptomatic, treat. Do not test without symptoms. That is one dictum. Now I'll tell you why these dictums are formed. So only if the patient is having significant dyspepsia pain, then only treat with PPIs. Or if the patient has got a high risk of development of ulcers, especially in patients who are on long-term NSAIDs, long-term aspirins, uh, on antiplatelets. So only in these patients you need to uh, like if there is a risk, only you need to start on PPI. Don't start PPI unless the patient is symptomatic or if there is no risk factors. Now, regarding H. pylori, so there is a very interesting thought process regarding the H. pylori evolution. So H. pylori is a organism that is very closely associated with human evolution. Uh, I am not sure. Are you familiar with the out of Africa concept of human evolution? So it's a thought that all human beings or all the Homo sapien species they developed or the initial ones were in the Africa, and from Africa we spread out to Asia and to the other parts of the whole world. So just like that, H. pylori is also seen like that. So there is a out of Africa concept of H. pylori is also there. Now it's also called as the African or the Asian enigma. That is, in patients or in people of African and Asian origin, the H. pylori colonization has been seen even in kids. And the percentage of H. pylori or the colonization is almost always very severe also. That is Africans and Asians. But despite this severity of colonization, the risk of gastric ulcers, gastric carcinomas is much less compared to the Western population. So the one thought is that an H. pylori is a commensal which evolved along with human beings, and there is a part of it which is called as the hygiene hypothesis, where the patients or people who were living in a less hygienic environment they have got a better immunity, and for them H. pylori is not much harmful, Africans and Asians. But in the Western population where they focused on hygiene too much, they have actually got a much higher risk factor for H. pylori, and in them, even a mild colonization can become pathogenic rather than just harmless commensals. So that is regarding the H. pylori. And one another aspect is also like earlier I told you regarding H. pylori being protective, right? So H. pylori is not just protective for in certain aspect of gastritis, patients with the GERD, and patients with the G junction malignancies, esophageal malignancies. In all these aspects, H. pylori has been found to be protective. That is why, like in patients with without other risk factors like smoking or alcohol, H. pylori presence of H. pylori actually protects them against esophageal and G junction malignancies. So that is regarding H. pylori. Then, and I hope I answered your question also. So there is no need to eradicate H. pylori unless if there is a like significant ulcers, and unless the patient is significantly symptomatic, there is no need to start PPI also.
Okay, sir. Thank you so much. Uh, Thank you so much, Akriti, as well. It was a very detailed and uh, interesting discussion that we had on peptic ulcer, and understand that it is a very large topic, as we had already discussed before the session as well. And we have yet to discuss the management of peptic ulcer in detail, the medical management, the surgical management, and the complications of each, and especially focusing on H. pylori eradication therapy, as well as the other important topics like gastritis, as well as Zollinger-Ellison syndrome, etc., that you have included in the later part of the presentation. I also thank Dr. Hari sir for his important inputs, both clinical, practical, and theoretical aspects. Uh, we will join soon for the upcoming session where we will cover the remaining part of this topic, as well as we will also take a new session, a new topic on the next session related to the GI diseases. Thank you so much, Hari sir. Thank you so much, Akriti, and others for joining in. We will soon upload this session on YouTube, and the link will be shared in the group. And I request everyone who had joined to please read the topics from standard textbook and come back again with newer questions and doubts, which we will be happy to discuss. Thank you so much, everyone.
Thank you, sir. Thank you, Shri.